Welcome to this special Gastro Girl podcast. This episode was produced in collaboration with the American College of Gastroenterology's Patient Care Committee. Here's your host, Jacqueline Gollin.
Hello, everyone. March is Colorectal Cancer Awareness Month, and we're doing our part to shine a vital spotlight on a potentially deadly yet preventable cancer. Colorectal cancer is second only to lung cancer as the leading cause of cancer deaths in the United States. Now, CRC affects men and women equally, yet few Americans know that colorectal cancer can be prevented, not just detected, through colonoscopy. If you're like many people, routine health care checkups and screenings, like colorectal cancer screening, may have been delayed due to the impact of COVID-19. But we're here today to arm you with the information you need to get back on track and take action. And I'm going to call it healthkeeping. And to help us accomplish this colorectal cancer awareness mission is the accomplished Dr. Neilanjan Nandi, who is not only a practicing gastroenterologist in the Philadelphia area, but is also an active and really engaged member of the American College of Gastroenterology's Patient Care Committee. Dr. Nandi is Associate Professor of Clinical Medicine at Penn Presbyterian Medical Center at the University of Pennsylvania. And he was honored, get this everybody, he was honored as the 2019 Physician Hero by the Philadelphia Delaware Valley Crohn's and Colitis Foundation at their annual Take Steps for Crohn's and Colitis event. And he is really active on digital and social media platforms where he really amplifies education, advocacy, and outreach in the IBD world for clinicians and for patients. And he's a fellow podcaster, everybody. And he focuses on, he's host of the academic podcast, GI Insights, IBD Crosstalk. And his podcast features very important evidence-based medicine discussions with guests from various different interdisciplinary fields that are really critical to providing comprehensive IBD care. And his passions include, I guess we share a lot of things in common, Dr. Nandi, fitness, cooking, although I'm not so good at virtual reality gaming, reading, and dancing, although my dancing ability can be questioned. But anyway, we'd like to welcome you to the show today, Dr. Nandi. Thank you so much. We're so excited to have you here.
Thank you so much. That's one of the most fabulous introductions I've ever had, and I appreciate that very much.
Let's begin with a little CRC 101. For those of us who may not know, what is colorectal cancer? What are the signs and symptoms? This is some basic information. Who's at risk and why is screening so important?
Yeah, absolutely. So first, this is March, Colon Cancer Awareness Month, and I'm so happy that you guys are bringing more light to this. If you're a patient or a family member or just someone coming across this, share this, not only listen to it, but share it with other people, because that's how we can actually get the word out and prevent colon cancer. So to your question, what is colon cancer? Well, cancer is cancer. It's a bad thing, right? Nobody likes that word. But cancer of the colon or the rectum is a mass of abnormal cells. Our bodies are made of cells. And if the cells don't function properly or don't replicate or make themselves grow properly, they can grow abnormally. And that cancer becomes a tumor that draws nutrition away from the rest of your body. Signs and symptoms of a mass in the colon are somewhat intuitive. If it gets large enough, it can block your colon from eliminating stool. So a change in your bowel habits. So if you start having lack of a bowel movement or having stool go around that mass so it comes out as diarrhea, some type of change or shift in your bowel habits that can last for more than 4 to 6 or 8 weeks, that should ring a red herring in your mind and talk to your primary care doctor. Other symptoms can be when that tumor outgrows its blood supply, because it's this greedy thing trying to sap up nutrition. It can ulcerate, it can bleed. You won't know it's bleeding. You may see some blood in your stool, but that's not very common. Usually blood in stool is hemorrhoids. If you see blood in your stool and it's persistent and not going away, you should talk to your doctor. Sometimes that tumor is higher up in the colon or lower down in the rectum near the hemorrhoid. So don't just assume. Again, if you see blood that's persistent in your stools, talk to your primary care doctor. The more common sign when it oozes, that blood gets mixed in with your brown stool and it gets mixed in to the point where you don't notice it. So that chronic low loss of blood can actually lower your blood count over time. A low blood count is known as anemia or a low hemoglobin. When you're very anemic, you can have a whole range of symptoms that may not make you think about a tumor in your colon. These symptoms of anemia are very not specific, but they include feeling really fatigued and tired, right? We need blood to carry oxygen to power our bodies. But when our blood count's very low, we get fatigued easily. We may get short of breath. We may find that going up a flight of stairs or lifting a box, or the kids, might be a lot harder than it used to be. So also, you can also feel very cold as well. So anemia signs and symptoms might be fatigue, shortness of breath, getting short of breath easily when you exert yourself, or feeling really cold. So we've talked about a couple of the things of colon cancer is a tumor or a mass in the colon or rectum. It can present with signs or symptoms of a change in your stools, the quality or consistency of it, constipation, diarrhea, blood in your stools, or just signs of anemia. But perhaps the most important thing to recognize is that colon cancer usually doesn't present with obvious signs or symptoms till later. That's why prevention is so key, and getting screened early is so important.
Oh, these are so important. These are so important points, and we're going to dive into them even more in detail. But, how do you get colon cancer? Can you catch it? I mean, these are really basic questions, but we don't know what causes colon cancer.
Great question. So like if you and I live long enough, we're going to develop something. Something's going to break. And if we live long enough, we can develop colon cancer or other cancers of the body. Colon cancer usually develops in the 7th to 8th decade of life. So we screen people decades before. The old guidelines used to say start screening at age 50. Now we start screening at age 45. That's 4-5.
And this is for average risk, right?
Average risk, right? Average risk. So just anybody who's approaching that age of 45 who doesn't have a family history or risk factors, which we'll get into, they should be screened. Now, why should you get screened at age 45 if you're average risk? Because there's nobody that's zero risk. We asked who gets colon cancer and why. And in my opinion, some of the bad things happen to good people. And just by being a human being on this planet, living and breathing, we're at risk for getting cancers just because of bad luck. And so if you start at age 45, for majority of people, that's going to be an early enough head start to look for growths in the colon before cancer happens. Now, we haven't talked about colon polyps yet, should we?
Yeah, let's talk about colon polyps.
I love talking about
polyps. We love polyps over here.
Now, maybe you've heard of a polyp before, but polyps in different parts of the body mean very, very different things. In the colon, polyps may refer to growths in the colon. So cancer doesn't happen overnight. Cancer is this mass, but usually the lining of the tissue of the intestine, the colon, is smooth and flat. What happens is cells grow, and these cells kind of lump up on each other. You can think of them kind of like a skin tag if you want to visualize it as a patient, but a skin tag is different than a polyp, but it's a growth. And these abnormal cells can sometimes be called colon polyps that are precancerous. Some colon polyps are not precancerous. They're entirely benign. Now, not all precancerous polyps are going to become colon cancer. I'll repeat that one more time. Not all precancerous polyps become colon cancer, which is good news. So if you have been diagnosed with a colon polyp, it doesn't mean you're going to get cancer. Your immune system, your body is so amazing, it will clear those precancerous polyps away on its own. But sometimes it doesn't do a perfect job. And those precancerous growths grow over time, over 5 to 10 years of time sometimes, before they get larger. And then if they're unchecked, meaning we don't find them and remove them for you, then sometimes those become colon cancer. So we start early, age 45 for average risk patients. We look for precancerous growths, polyps. If we're unsure or whatever, we just remove those suckers. We get rid of them completely, and we prevent them from going on to become colon cancer.
Those little suckers, they're just so bad. And they can be so good too, because you just get them out of there and you have a clean, nice, pretty colon again.
Yes.
But no, on a serious note, you really laid out a very important description and lead us into our next important area of screening, and why colonoscopy, like I said in my introduction, is so important, because it can not only prevent colon cancer, it can detect and remove those polyps and prevent them from turning into a cancerous polyp.
That's right.
Can you explain a little bit about that?
Yeah, there's many different ways to get screened. Okay. And that's the luxury of this. So I'll step back and say, if you're listening to this, chances are you're like most of society and you think talking about stool or poop is taboo. But I'm here to tell you that stool is cool, okay? And that looking in the gut is important. And, I know it's funny to say, but we have to bring light, right, to destigmatize this procedure.
I think it's cool. In fact, I had a colonoscopy several years ago before I was diagnosed with IBS, and they were trying to rule out other things. And I'm such a geek that I actually stayed awake for a little bit at the beginning so I could watch on the monitor to see what was happening. They fill your colon with gas, right?
Yes.
They inflate so they can see better. And it was really wild to see the results of a perfect colonoscopy prep, but also what's happening. And it's not as bad as you think, honestly. And when you wake up, it's like the best sleep you've ever had.
Now if you're listening to this, she's just bragging because she had a perfect prep, right? But which is great. But no, that's right. And I'm so glad that you got to see it, and let's talk about that too. So back in the day, to address a couple, so we're going to talk about stigma. One, we look through your bottom, okay, through the rectum, but most patients, okay, I'd say 99% of patients are asleep, sedated, comfortable. And that way we can take a look and it's not awkward or uncomfortable for you. And there's no shame in that because we're preventing colon cancer.
Yes.
You are taking charge of your health with a colonoscopy. So we should really get rid of the stigma that might be associated with going through a colonoscopy. I don't know a single person who says after the fact that that doesn't wish they couldn't have prevented their colon cancer by early screening. So the different modalities are, we're going to come back to how we do a colonoscopy, but X-ray, stool tests, and then colonoscopy. And the punchline is, I believe, and I'm biased, but I believe that colonoscopy for the majority of people, unless there's a medical reason you can't get screened, colonoscopy is the gold standard way to get screened and remove polyps, to do proactive removal. So the non-invasive tests, where we don't go inside your body, include doing stool tests, where you give us a stool sample, you smear some stool on a card, you mail it back to us, or the primary care doctor or gastroenterologist does it in their office on a card. We put some chemical on it, we look at it, okay, like a developer, and we see if there's any microscopic blood that might be in the stool. Remember I said blood's not always positive, right, or visible. And if it's positive, well, then it does not mean that you have colon cancer. It just means you might have had hemorrhoids, you might have had a lot of red meat to eat that day, a million other things that could have caused that to be, well, not a million other things, but a few other things that could have caused that to be positive. But maybe a small chance that there's colon cancer, we send you for colonoscopy. So if the stool card test is positive.
So you end up having a colonoscopy anyway, which is, like you said, the gold standard. And it's also an important part of the ACG's guidelines.
That's right. That's right. So if you're going to get a stool test called a fecal occult blood test, we tell you to get it annually. If you're going to rely on that type of testing, but important thing you just said, which I love, is that, well, if it's positive, you're going to get a colonoscopy anyway. So if you're going to do the test, be prepared to tell yourself that if it's positive, you will follow through with the colonoscopy. Because if you don't, there's no point in getting the test done.
Wow. God, it's so important. And we're making light of it because we want to remove the stigma. And honestly, I think going to the dentist is worse.
Well, most of the time you're more awake for that. You got to hold your mouth.
Exactly. No, it's really not that bad. And, a lot of people write in or they talk about when they talk about it's the prep. Now, when I first did mine, the prep was not as easy. The first one was more, there was like a big thing I had to drink and then take these pills. And it was a little rough, I will admit, but I survived. But my second one was much easier. It was like 2 little bottles and it was like split dose and it was easy peasy, honestly. This is another question that comes up. What does insurance cover? Do they cover the stool test and then do they cover the colonoscopy? Or here's where you really have to talk to your physician about what your risk factors are and what the best test is. Because isn't there something with the insurance that they may not cover? And again, don't, hold me to this. But I think I'm like most patients trying to figure out what's covered, how do I make the best choice? Because if my stool test is positive, I still need a colonoscopy. Are they going to pay for those or do I have to pay for something?
You bring up a great point, which is this is changing. So you have to check with your own insurance provider. Yeah. But what you're appropriately addressing is that some insurance companies will say that if you elect to do a stool DNA-based test for colonoscopy, if it's positive and you need a colonoscopy, they won't pay for the stool DNA test. Now, that's not true of all insurance companies, but many to date are like that. There may be some exceptions. So I would say, ask your doctor, just like you said, number one. Number two, call your insurance company. Find out what the deets are. You don't want a big bill, but then certainly remember that if it's positive, you should do a scope. A scope means colonoscopy in GI lingo, if we're being cool about it.
Yeah.
The other tests that we can do for screening are X-rays. There's a test called a barium enema where
interesting.
Where you do a colon prep. And a colon prep, we haven't talked about it yet fully, but it means you drink a gallon of solution basically to clear out all the old stool. And then they infuse contrast or some type of X-ray agent that allows us to see your insides in through the rectum. Not the most fun test to do, a little awkward, but we're all professionals and we take care of you and do a really good job, our radiology technicians. And they turn your body so that the contrast coats the outline or the shape of your colon. Now, that test is still available. It's a good test. But guess what? If you're not fully cleaned out, a ball of stool may look like a polyp. And then you need a colonoscopy again, right? So
why would somebody elect to do that one?
So for all of these non-invasive tests, these tests that aren't colonoscopies, right, where we take a camera and look, these tests really should be done if there's an absolute medical contraindication, like you are have some cardiac disease or pulmonary disease, lung disease, where you can't tolerate anesthesia, sedation, or you can't tolerate the procedure. And this doesn't mean that you don't believe it. It means that your gastroenterologist, your primary care, your cardiologist, your lung doctor, or other specialists think that there's a medical reason that doing a colonoscopy might be a danger to your health for some reason, or risk, the benefit isn't there. So they might do a non-invasive test, stool or X-ray, to look first, and then say, well, if it's normal, great. We didn't expose you to any risks for you of doing a procedure. But if there is a finding, then you guys come back to the drawing board, to the discussion table rather,
nice.
and then reevaluate whether it's appropriate to go find whatever they saw with a procedure. So that's why we do these tests available.
That's great, because we always like to empower patients with more information. They can talk to their doctor, and we always encourage the collaborative approach for patients in discussions with their provider. Feel like you're an empowered participant and partner in your healthcare, not just, okay, I'll do this, especially, those that really are into research and understanding their options and the latest guidelines. Go to the ACG site, gi.org, and you can search or look under education and guidelines, and you will be able to see the latest colorectal cancer guidelines. And they do have the tests and what they recommend. And it's a good foundation for, talking with your doctor about. Would you say?
I totally. And, the gi.org foundation, our website has all the documents that you said, written information, also some great graphics and illustrations, depending on how you like to learn, that I think are helpful. And several of our patient handouts are in Spanish and other languages too. So
that's so important.
Yeah.
And I know there's things that are coming down the pipeline. I know there's something called there's a little pill you swallow, and I don't know if that affects colonoscopy or the colon, and then people talk about virtual colonoscopy. They may hear about that. Are those recommended at all, or are they just still too new?
There's CT colonography, which is another type of X-ray test essentially, but a bit more sophisticated than a regular barium enema X-ray. It's the same concept. You drink a prep, you drink some solution, and then they do a CAT scan on your body. And then it's kind of cool. They recreate your intestine in 3 dimensions, and you can fly through it and look for polyps and whatnot. But again, polyps could be mistaken.
I was going to say something, but
that's another.
I hear superhero, leading the charge through the colon, but maybe that's for several years down the pipeline.
That sounds like a blockbuster video game to me. But
yeah, virtual reality. There we go. We need to team up on that one.
There you go. But the disadvantage, so the advantages are you don't have to have a colonoscopy, anesthesia, sedation. Some of the cons of the test are that if it's positive for a polyp, you need a colonoscopy. If there's stool, it may look like a polyp or a mass, you need a colonoscopy. Lastly, there's a lot of high dose of radiation, and we're really trying to minimize radiation into people's bodies because the more CAT scans you get over your lifetime is associated with some increased risk of cancers throughout the body. So we don't like to do it unless we have to. You mentioned a capsule. It's like a multivitamin, size of a multivitamin. It's got 2 cameras on each side. We call it a capsule endoscopy. You swallow it. You have to prep your colon. You swallow it. And then you wear a little belt recorder, and it wires all the images, pretty cool, to the belt pack. And we already do this for the small bowel. And now they've developed it for the large bowel. And that data for polyp detection is still emerging. It's looking very promising, but there are some potential cons. And the guidance on this is really developing. It may be challenging to determine specifically where the polyp may be in the colon. But then, of course, if you do find something on it, you have to do a colonoscopy.
Well, yeah, and I was just about to say, and all roads lead back to the gold standard, which is colonoscopy. And I love how you laid out all these different options, but at the end of the day, still the best test, it always is the one that gets done. But in terms of the colon of, really what can prevent, not only detect, but prevent colorectal cancer is the colonoscopy. And oftentimes patients will need to have one if there's something that's detected in any of those other tests.
And to be clear, we've been talking about pros and cons of each test. And to emphasize the point, the difference between a colonoscopy and everything else, the stool and imaging tests, the X-ray tests, those tests can screen, but they can't remove. And when we talk about prevention, we're talking about detecting and removing those precancerous colon polyp growths. That's the beauty of colonoscopy. That's the capability of colonoscopy, that you can do it in one shot and then be rest assured that, my doc was able to find them. I did everything I can, and they've reduced my lifetime risk.
Yeah, that's so important. Now, I want to talk about another, I know that there's been so much emerging science on young onset colorectal cancer, even younger than 45. There's also, more information about the role of family history, not just your mother and father. Could you talk a little bit about that and really, young onset colorectal cancer and the relation with family history and why that's so important?
Yeah, absolutely. So one of the motivations for moving up the guidelines in age, one of those motivations was that we were finding that up to 15% of colon cancers were being diagnosed before the age of 50. And like I said, it doesn't happen overnight. So we were finding, that we were missing early colon cancers and that we really needed to start screening earlier. And so that's one of the most, powerful reasons for why we actually changed the guidelines. There also turns out that there's many environmental risk factors too, and family risk factors that may contribute to the development of colon cancer. Let's talk a little bit about the
this is so interesting.
If you know somebody like a first degree relative in your circle, we're talking parents, mom and dad, right? And if they've had colon cancer, that can increase your individual risk by 2 to 3 times. Okay, that's not a small number, right? That's
pretty big.
Yeah. And I think if you and I wanted to decrease our risk with that family history, we would want to, probably, right? Most of us.
Yeah.
So we say get screened 10 years before the age of diagnosis of that family member. Why 10 years? Because on average, it takes about 10 years for something small to become something bad. And so we say screen 10 years before the age of that family member. So if your family member was diagnosed with colon cancer at age 45, you, as their sibling or parent, would be screened at age 35, okay, as an example. Now, if you're past 45 and it's right 45 on the dot, just go get screened.
The other thing that I wanted to talk about, and this has been getting a lot of attention as well, much deserved attention, is the disparities that exist for not only for health in general, but for things like colorectal cancer screening and awareness. And what do we need to know about the disparities that exist, and how can we reach those populations of patients that this affects?
Yeah. This is very passionate to many of us right now. We live in a country where we have, the luxury of a healthcare system, and yet the travesty of this wonderful system that we've established is that healthcare is very inequitable. We don't have equal access, and some of our most vulnerable populations are being underrepresented by less access, lack of access to proper screening. So some of our most at-risk populations, especially for colon cancer, are African-American communities, Native American communities, and Hispanic communities, which is a travesty because they're part of this, melting pot, rich culture that we have in the United States, and yet they're not getting as equal an access as the rest of the population to basic colon cancer screening. So data definitively illustrates that those specific populations are not getting the recommendation to screen early enough, or are getting those recommendations, but it's not being executed for a number of socioeconomic reasons that disadvantage those populations. And, American College of Gastroenterology has multiple initiatives, including this one, right, to get the word out, to try to help people empower themselves and to help the clinicians and the healthcare infrastructure increase the colon cancer screening rates in these populations.
Well, what's so alarming to me is when you look at the statistics, you see that, especially among the African-American population, that oftentimes by the time they are aware or they find out that they're finally diagnosed with colorectal cancer, they're diagnosed at a later stage, and it could be mortality is affected, like the increase in survivability of the cancer, and that shouldn't be happening in today's society in our country.
Right. 100%. And, to talk about survivability, that's another reason that sometimes, some patients, may have some, psychosocial mental block, if you will. They don't want to know. They may suspect that they may have something bad, or they're so fearful of it that they don't want to get screened. It may not make sense to everybody, but it happens more times than not, where patients just don't, they're scared of the unknown.
Yeah.
But what I want to counter that with is what you just said. If we detect cancer early, which we do all the time, we can have 90% cure rates, which is unbelievable. You don't think of cancer and cure all the time, right?
But no, this is what's so amazing about, not amazing about colorectal cancer, but it's, no one wants to get colorectal cancer, but in the light in this is that it can be cured, if you will. You can prevent it. You can survive it if it's detected early enough.
That's right. I have this 3-2-1 thing that I share with patients when I'm trying to convince them to get their colonoscopy. I say that colon cancer is the third most common cause of cancer death. It's the second most commonly diagnosed cancer, but it is the number one most preventable and very treatable cancer. Just because we screen you, we find it, we know how to remove it safely, and you can live a cancer-free life with cure. But if we diagnose you later, the cancer survival rates fall to anywhere from 5 to 15%, depending on what later stage you are.
Yeah, and we have to do, we're working on some things with Gastro Girl, the GIOnDEMAND in the college, and hopefully, we'll be able to reach those populations in a more grassroots level, because many don't even have access to the internet to even find out. They may not even listen to this podcast, unfortunately. So we have to figure out grassroots ways of reaching those populations sooner rather than later. So
I'm glad you brought that up. There's several ways, and lack of smartphone access, or rather data access, is a real issue still. Throughout much of the world, including the U.S. That may surprise some of our listeners, but it really is. I think grassroots efforts involve, and these are happening through our programming and through our patient advocates and through our clinicians, is going to our temples, our churches, our mosques, are going to our community centers, and even some of my colleagues at Penn are doing that right in the local community, and going to the trusted leaders, cultural community leaders, because those are people of trust too, that can disseminate this information and increase screening. So if you're listening to this, you feel inspired, reach out and we can help you partner or bring this information to your community too.
Yeah, I think, I've read over the years, at the hair salon or the barbershop level in some of those communities where people go every week. It's such an important vehicle, a venue for getting that information out. I thought that was so important. That's so right. It's good. It's good to hear that there are things going on, and we have great organizations like Fight CRC, the Colorectal Cancer Alliance, and many other organizations that are working together to really address these issues. The advocacy efforts on the policy side this past year, that polypectomy surprise went away, right? Where patients had to worry if they would be charged by their insurance if they found a polyp and had to go back or something like that. And now that doesn't exist anymore. So that's good news.
Yeah. They were getting surprised if they got a subsequent bill,
they would get a bill
for that. Which fortunately, if you're listening to this, the whole point is to, ACG has worked hard, patients have worked hard to lobby for greater patient benefit on these types of rulings that say, if you get a screening colonoscopy, which is a proven successful preventative exam, that if something is done during that procedure to remove a polyp or whatever it takes, that you're not getting charged an extra bill.
Yeah.
You are doing your part for your own health and for society's health. So, you should not get an extra bill because of that. And so patients can sleep better, that they
Yeah.
can go to a colonoscopy, relax, and not be worried about these excessive bills later.
Oh, that was huge. That was a huge accomplishment on the part of the advocacy organizations. So that's great news for patients. I know we could talk all day about this. It's so important, but I did want to touch on, the colon prep aspect.
Yeah.
Come back to that. What are some of the options that are out there for patients, and dispel some of the myths like, oh my God, it's the worst thing ever. Shed some light on that.
Yeah. So I'll tell you what, there's almost no way. I'm going to be level with you and honest with you. And when I say you, I'm you and the patients, right?
Yeah. And I've done this a few times, so I can speak from experience.
Yeah. Nobody should tell you that colon prep is easy. Some patients, it's no problem, but it's a necessity. Stool is like mud. All right. You got a lot of mud on the road. You got to get that garden hose out. You got to wash it off. Okay. If you want to clean pave. And so we have to give you a lot of solution in order to wash that stool out. Now, depending on your own individual health, you may be a candidate either for a full prep, which is about 64 ounces of fluid. Okay. Or you may be a candidate for half prep. Okay. A half volume prep. If you have, any degree of, or some degree of cardiac or heart disease or kidney disease, that may be relatively contraindicate or prevent you from the half volume preps because they have more electrolytes. You and I are like a bottle of Gatorade. We run on electrical currents, and we don't want to shift your electrolytes too much with a half volume prep if you have any risk factors to affect those electrolytes. But if you don't, and many patients don't, then you get a regular, 64 ounce prep. And it's usually better tolerated than most people think. Most of the time, most patients will come back and say, you know what, doc, that wasn't
what
so
about
bad.
the split? I did the first one. I think I did the whole big thing, but then I did the split prep, and that was so easy.
The split dose.
Compare.
Yes. So split dose means that, if you have, we have you take the prep, the 64 ounce prep, and split it in half. So you drink half of it maybe the night before, and the next half the morning of. And what that does is it keeps your prep cleaner. We oftentimes use this for afternoon procedures, because if you have an afternoon procedure and you do the whole prep the night before, when you wake up in the morning, your bowel's looking pretty clean. But if you wait a couple of hours, old stool in the small intestine kind of trickles down and makes the prep poor again in the large colon. So by splitting it up and doing like a second half chaser later in the morning, but before your afternoon procedure, we can keep the bowel prep clean so that the doc can survey your bowel and remove any polyps that you may have.
And I think there's some tips and tricks that, some patients can follow with the help of a dietitian or their nurse practitioner. I think you can sip plain chicken broth, or chase it with I think it was Gatorade, something I remember, but definitely, don't listen to me on this one. But I remember I was alternating, and the nurse practitioner said you could do it if people worry about their, low blood sugar, or they're going to, feel really hungry. There's little tips and tricks that can make it more tolerable, but definitely you want to talk to your physician or nurse practitioner about that.
That's right. I'll give you my top couple tips real quick. If you have any degree of constipation and got to push or whatnot, or have, smaller stools, tell your doctor, because you might need a little bit more adjustment to your prep to prevent a poor prep. If you have a poor prep, we can't see because there's stool, because you're baseline constipated, then, we should know that in advance. But if you poop regular, a couple of the tips are drink a lot of water during the day that you're on clear liquids. So you're usually on clear liquids the day prior to the procedure. Hydration is important. If you're dry, prep doesn't work as well. Also, when you're drinking, you can have clear liquids with sustenance, with sugar like broth and Gatorade, electrolytes, Jello, to keep your blood sugar up. But when you're drinking the prep, a lot of people, they take the whole gallon and they put in like one flavor, right? They might get some, I don't want to mention brand names, but they get a flavoring packet, okay? Be it, whatever flavor, and then they get sick of that flavor. So what I recommend to my patients is get a multi-pack, get a lime, get a lemonade, get a couple different ones, orange. And then instead of diluting the whole gallon, you want to chill it, by the way. You pour it into a cup and you put a little bit of the powder into the cup. That way you can change the flavor up. Nice. You can also chew gum, lozenges to get, if you don't like the taste for some reason. And then these types of little tweaks can usually make the prep a lot tolerable. And then I mentioned chilling it makes it a lot better.
Yeah. And, if you're like our producer, Lori, she probably drinks hers in on a martini glass, chilled her preps.
That is the most sophisticated way, darling, to drink prep.
There was a physician, I forget, he was on the ACG on one of the committees, and he and his neighbors all turned 50 at the same time. They actually had, as part of Colorectal Cancer Awareness Month, they actually had a colon prep party where they all prepped together for their colonoscopies.
That's funny. One time for my residents, this is many years ago, I lined up little shot glasses, little plastic medicine caps, and I had all my residents taste the different preps one by one, just so they know.
Like what's better, this one or that one? Yeah, the second one that I had, it was 2 smaller bottles, and it was like really easy. But I did some of those tips because the first one wasn't as easy as the second time, but it evolved since that time period.
That's right. And those smaller volume preps, and they're available. Talk to your doctor, and they'll tell you what's the right one. Many of them are covered by insurance, or there's a small copay, or there's coupon cards. But they make the prep, if that's your concern, which it is, understandably, it's a lot of volume. There's ways around it, or there's strategies. And so we know how to counsel patients to get them to that prep. The prep is the, in quotes, hard part, oftentimes easier than you think. And then to go through the procedure itself, people enjoy the sedation, great sleep, and they come out feeling well, and they've taken charge of their health.
Yeah, I thought it was the best sleep I've had in a while, honestly.
Yeah.
But, is there anything that we forgot here? We want to mention again, all roads lead back to colonoscopy as the gold standard. Don't be afraid of it. If your doctor recommends it, don't be afraid of it. And hopefully we didn't miss anything. Is there anything else that we should touch on?
I think there's one thing I'd like to talk about, which is lifestyle.
Yeah, that's an important one.
I think that, we're looking at epidemiology, public health policy, and we see that chronic illness is increasing and only on the rise. And we have to focus on prevention. So here we're talking about colon cancer prevention by looking for colon polyps, colonoscopy. But there's something that we can do day to day, even before or between our scopes, which is eating right and getting fitness. And so when it comes to eating right, diets that are higher in fiber have been associated with colon cancer prevention. Diets that are high in red meat consumption, particularly those that are charcoalized red meat, like a steak that has some char, it changes the chemical structure of the meat. The red meat specifically, that has been associated with the development of colon cancer. That's recognized by the World Health Organization. Also, diets that are high in consumption of alcohol and tobacco. Tobacco doesn't make almost anything good, but those have also been associated with risk of colon cancer. So there's a lot of dietary lifestyle things that we can change. And then lastly, fitness. My social media moniker is FitWitMD, Fitness Witness, because being conscientious about fitness and what I put into my body has transformed me. And I didn't learn or put this into effect until I was really an attending, believe it or not, sadly. But fitness has also been associated with healthy lifestyles, healthy outcomes, and keeping the midline in check. When our midline, our waistline, is heavier or more set, increased BMI, body mass index, has been associated with the increased risk of cancers in general, including colon cancer. So eating right, making sure we're not putting excess toxins in our body, and having good fitness, those are key and widely beneficial lifestyle measures that we should all implement to prevent colon cancer.
So important. I'm glad you mentioned that because it's so critical. And even something like you do dancing, like what kind of dancing do you do?
You brought that up. Yeah. So
I had to. I mean, I've never seen that on someone's bio. So I have to ask the question.
I love to dance. Anybody who knows me, I will dance anywhere in endoscopy or at the club, but I love to dance Latin music, salsa merengue. I like bachata, although I'm still learning that one.
That's so
hip hop. In college, I used to do a lot of swing dancing and talking to my wife about getting back into that too.
That's so awesome.
Yeah.
Maybe you should have a little, at the next annual meeting, you could have like what do you call those group and everyone gets together in the middle of the field or something?
Like
the mob, like a mob
like a
dance.
flash mob. Oh, that would be fun.
The colorectal cancer flash mob.
You know what I would love at ACG is like a dance marathon fundraiser for colon cancer. That would
be a great idea.
Yeah.
Well, maybe we can make it happen.
That'd be cool.
That would be so cool. Well, this has been such a great conversation. I'm so grateful to have talked to you today and finally met you in person virtually. I hope we can talk again. This has been, I hope our patients and our listeners out there found this valuable, as I know I did. I always learn as well when I listen to what our clinician experts are telling us. So thank you so much. And we look forward to working with you again, and have a wonderful weekend.
Thank you very much. And I just want to say thank you for doing this and promoting such great education for all our patients. And again, to our patients, please share. That's how we all become more empowered with more learning.
Yeah, and again, keep up the great work with the ACG's Patient Care Committee. And we look forward to doing more of these with you guys.
Thank you for listening to the Gastro Girl podcast. For more information and resources, please visit gastrogirl.com. Do you have a question for Gastro Girl? Please email podcast@gastrogirl.com. The information, opinions, and recommendations presented in the Gastro Girl podcast are not a substitute for medical advice from your healthcare professional. Please consult a licensed clinician in your state regarding all matters related to your health.